Everyone, and welcome. I am Allison Burriette, the Director of Philanthropy for the IDSA Foundation, which means that I inspire individuals to give to the mission and vision of the IDSA and the IDSA Foundation. We're just thrilled that all of you have joined us here as we commemorate Fungal Infection Awareness Month and host our first webinar of 2023 as part of the John G. Bartlett Memorial Education Series. Today's webinar is titled The Fungal Foe Among Us. And before we proceed, I'd like to take a moment to acknowledge and express our sincere gratitude to our silver industry partner, Melinda Therapeutics, whose support has made this webinar possible. Thank you to everyone at Melinda Therapeutics for their support. Now let's cover a few quick housekeeping matters. This webinar will be recorded and made available for you for viewing on our website, as well as on the IDSA Foundation YouTube channel. In case you're unable to stay for the entire webinar, we want you to feel free to access this webinar on demand at your convenience and share it with others. As you may have noticed, all of the attendees have their microphones muted. However, we hope that you will actively participate by using the Q&A button and ask questions at any point during the webinar. We are going to have dedicated time at the end of the meeting for question and answer session with our speakers, and we hope that you'll stay and ask your questions at that time. In the unlikely event that we are unable to address all of the questions during our live session, we are going to make every effort to respond to your question via email. Now, I would like to introduce our host and moderator for today, Dr. Mary Rose Lagiovilla. I'll let Dr. Lagiovilla introduce herself, but I just wanted to say thank you so much for joining us, Mary Rose, and welcome.
Thank you so much, Allison. I'm honored to be here. Well, good afternoon, Dr. Lagiovilla, and I'm very excited to introduce to you our two expert speakers who will be discussing this important and clinically challenging infection, Candidemia and Invasive Candidiasis. First, we have Dr. George R. Thompson. He is a professor of clinical medicine at the University of California, Davis School of Medicine with a joint appointment in the departments of medical microbiology and immunology and internal medicine. Pardon me, my pager is going on. As most doctors will. Dr. Thompson specializes in the care of patients with invasive fungal infections, and his research interests are in fungal diagnostics, clinical trials, novel antifungal agents, and host immunogenetics. Dr. Thompson has also served on the IDSA Journal Club, is a member of the Coccidioidomycosis Study Group Planning Committees, and is the chair of the Mycosis Study Group Education Committee. Our second speaker is Dr. Jose A. Vasquez. He is the chief of the Division of Infectious Disease and professor of medicine at the Medical College of Georgia at Augusta University in Georgia. He joined Medical College of Georgia in August 2013, and prior to this, he was professor of medicine in the Division of Infectious Diseases at Wayne State University School of Medicine and senior staff physician in the Department of Medicine, Division of Infectious Diseases at Henry Ford Hospital and Medical System in Detroit, Michigan. In addition, he is currently the chief of the Antimicrobial Stewardship Program at AU Health Hospital and chair of Biomedical IRB Committee at Augusta University. Dr. Vasquez has published over 500 manuscripts, abstracts, case reports, and book chapters on various infectious disease topics, especially in fungal infections and polymicrobial biofilms. Dr. Vasquez's research includes the epidemiology and management of mucosal candidiasis, invasive candidiasis, as well as the management of systemic fungal infections. So as you can see, we have two excellent speakers today, and it is my pleasure to introduce to you first, Dr. George Thompson.
Thanks so much for that nice introduction. It's really a pleasure to be here and to talk about invasive candidiasis and candidemia. Here's Dr. Vasquez and my disclosures. Next slide. So we were really tasked with 5 different objectives today, and we'll go through these in detail over the next 30 minutes. So really to talk about the Candida species that are really affecting our patients that cause candidemia and invasive candidiasis, to talk about the risk factors and identify the groups at risk for these infections, to really examine how we can diagnose these patients earlier, what's practical, what can we do to really try to develop preventative strategies for our patients, and then to look at the current trends in antifungal resistance among different Candida species, And then also, where are some areas where candidemia prevention can really be built upon with infection control and intervention strategies? Next slide. So invasive candidiasis is really a very important disease, obviously. It's the fourth most common bloodstream infection. It's 10 to 15% of cases overall. It has a very high associated mortality rate, up to 40% in some studies. There really have been some pervasive taxonomic changes throughout the field of invasive candidiasis that I think have frustrated clinicians, and we're going to talk about that just a little bit. And then really, can we define who is at risk? What are the risk factors for invasive candidal infections? And certainly risk factors for non-albicans Candida species. Which new species have really emerged as a significant problem, and what are the resistance aspects that have really swept across the field of invasive candidiasis, but mycology as a whole? And then how can we establish an early diagnosis and get these patients on treatment? And then talk just a bit about ocular examination in these patients. That's been an area of increasing controversy over the last few years. Next slide. So there's been a lot of taxonomic change within the field of candidemia and Candida, and you can see these outlined here. Candida albicans really has not had a change in name, fortunately. Again, that's the most common Candida species that we see, but Candida glabrata, the updated taxonomic name is Nicasiomyces glabrata. Candida krusei has been moved to the Pichia genus. Parapsilosis and tropicalis are unchanged. Candida guillermandii is now Myrozyma guillermandii. Candida lusitania is now a clavispora species, and then Candida auris, which we'll talk about as well, has not been renamed. The good part about this is most labs have wisely started to list these isolates like we've outlined here. They'll have the new name and then have formally in parentheses, but this has caused a lot of confusion within certainly our hospital and others we've talked with. To identify these organisms, it really confuses the non-infectious disease consultant who may not be aware of these taxonomic changes. So just to be aware of that, and if your microbiology lab has not sort of adopted this nomenclature, I do think that they need to do that and then put the former name certainly in parentheses, as you can see here. And Sarah Kidd has a really nice article with colleagues in OFID just earlier this year, outlining kind of the why and the behind the scenes for why these changes have occurred. Next slide. So what are the risk factors for invasive candidiasis and candidemia? And a lot of these are overlapping. Patients will often have more than one of these risk factors. You can see these outlined at left, and really the primary one we see in our patients is the presence of an IV catheter, central venous catheters in particular. Those not only provide direct access to the bloodstream, but anything that really disrupts the barrier, the skin barrier in this case, is going to be a risk factor for invasive infections. TPN is an established risk factor. There's some nice studies looking at Candida growth in vitro in a variety of different TPN products. Really, any of those that contain lipid are at high risk for Candida species. Post-procedures, primarily those that transect the bowel wall, can have microscopic spillage into the peritoneum. That's certainly a risk factor for Candida. It's just within the gut. Broad spectrum antibiotics, clearly microbiome changes occur with this. There's also been some pretty interesting data that the NIH has published with vancomycin in this regard. Vancomycin specifically with microbiome changes decreases Th17 immunity, so that's a further risk factor for invasive fungal infections. And then colonization, broad spectrum antibiotics are going to change the microbiome of both the gut and the skin, and we generally are infected with what's already on us, so that's clearly a risk factor. Chemotherapy, especially mucositis, is going to be a risk factor for invasive Candida infections. And then transplant and other immunosuppressive conditions are clearly risk factors for all infections, and particularly mycotic diseases. And then the last one you can see here at bottom right of our figure is metabolic derangement, particularly diabetes is going to be a big risk factor for Candida, and particularly urinary candidiasis. Next slide. So to talk just a bit more, and we'll go through this slide a little bit slower, as you can see this figure here on the left, that candidemia, really it starts primarily from the skin or the gut. And you can see here just a visual example of that with spillage from the intestines into the peritoneal space. And following candidemia, it can certainly set up shop in a variety of sites around the body, or it can have a primary focus at those sites and then cause candidemia from those. So as we go to the right, you can see from a catheter, that's certainly a risk factor for candidemia. They can also be seeded by preceding candidemia, kidney disease, pyelonephritis, renal abscesses, urinary candidiasis that can be ascending infection, or they can develop pyelo from concurrent candidemia. Splenic and liver disease certainly can be seen. Endophthalmitis can be exogenous or endogenous in nature. And then lung, that's primarily pulmonary abscesses. Candida pneumonia is really not a syndrome for a variety of reasons that we won't go into. And then bone disease with Candida, we certainly see often from trauma or post-surgical, but it's certainly a complication that we see from candidemia. And then where are these patients located in the hospital? I think historically we've thought these patients are primarily in the ICU setting, but you can see from this study, only about a third of the patients are within the medical or the surgical intensive care unit. And really the vast majority of patients are on just our medical and surgical floors. So we do see these patients outside of the ICU. There's really been a large increase in the hospitalist movement nationwide. So I think hospitalists are very aware of this problem now, and it's no longer just an ICU problem. We see these patients all over the hospital and even sometimes in the outpatient setting. So important for really all areas of medicine to be aware of Candida and the complications of the disease. Next slide. So to talk just a bit more about the epidemiology of Candida, and you can see these different pie charts here, there's really been a shift to non-albicans Candida species. And if you go up to the top there where it says figure A, you can see in the left portion, these are really the spread and the breakdown of Candida species for those who did not receive any antifungal prophylaxis. So you can see gray is the vast majority, that's Candida albicans, with Candida glabrata and Candida krusei, two that we worry about primarily from azole resistance, only make up about a quarter of the cases. If a patient received less than 7 days of antifungal prophylaxis, which is very common in our early on in the course of our chemotherapy patients, you can see the etiology of their candidemia has not significantly changed from those with no prophylaxis. But as we move further to the right with longer durations, more than 7 days of antifungal prophylaxis, you can see glabrata and Candida krusei, which are these red and blue, now make up over half of the cases. So it's really important to look through your patient's prior meds when you first approach therapy for invasive candidiasis, but don't know the species or the susceptibility pattern quite yet. So as we move down to the bottom where it says figure B, this is a distribution based on antifungal agents used for prophylaxis, but goes through no antifungal prophylaxis, different studies, so the breakdown's a little different. And then by fluconazole prophylaxis as you move towards the right, or caspofungin prophylaxis all the way at the right side there, and you can see with caspofungin prophylaxis, you see a big increase in Candida parapsilosis, which does have higher MICs really across the board for the echinocandins. Next slide. So those are two specific studies and kind of show the typical breakdown for candidemia and invasive candidiasis. But you can see here from this nice paper by Pete Pappas and colleagues in Nature Reviews that it's highly specific on the exact geographic location. So this does not include Candida albicans in these bar graphs, but you can see glabrata followed by parapsilosis and tropicalis in Canada, France, and the United States. But in some of the other locations, like in Denmark, they have a lot of Candida glabrata. You can see it's up to 30% prevalence in that particular report. And then Japan has a prevalence of Candida parapsilosis, as does Brazil. So it's not so important to know these global statistics, but it's important to really know your regional epidemiology as you approach therapy for these patients with invasive candidal disease. Next slide. And then as we move on to Candida auris, Candida auris has been in the news a lot the last couple of years. I think that most people are familiar with this now. It was really first described as an ear culture isolate in a patient in Japan in 2007. And then when people have looked back into their culture databanks, there's really, the first description was in South Korea in 1996, but overlooked for a while. It was misidentified as a different Candida species originally. But this is what we've presented here as one of the original description of Candida auris infection. It shows the very high associated mortality rate. 4 of these 7 patients died. Most of these patients do have serious underlying conditions. They have a lot of risk factors for mortality, not just from Candida auris, but just in general. And the other problem is a lot of these isolates are fluconazole resistant up front. Enough that really that fluconazole is not the recommended therapy for these. It's going to be an echinocandin up front. It's also important to recognize echinocandin resistance certainly can occur in Candida auris. That was seen even in this original description, but really become a problem. We'll talk about that in more detail in the next few slides. Next slide. And you can see here where this came from. And it's really pretty interesting. There's been a lot written on this over the last few years. They think it's really independently emerged with 4 clades across the globe at the same time. Each of these really represents clear ongoing transmission within each region. And you can see here really the cluster and clade analysis of how these are related to one another from the phylogenetics in the top right there in figure A and B both shows the number of clinical cases. But again, the importance of this is here on the left side, the resistance profile of Candida auris. It's very frequently azole resistance, almost always. They develop rapid resistance on therapy. And then it's a significant infection control issue. Quaternary ammonia compounds, which are often used to clean rooms, really are not effective for Candida auris. So bleach needs to be used for terminal cleaning of these patients' rooms. Next slide. And then this is to zoom in just a bit more on the United States. The United States has really cases from all 4 of these different clades. You can see here, this is a bit dated of a report now about 5 years ago. Obviously, COVID has really impacted epidemiology understanding of these diseases, but we now are seeing this across the country. If you haven't seen a case of Candida auris yet, it's probably coming within the next year or two, so important to recognize that, be able to take appropriate precautionary measures for those patients to really prevent the spread of that. It really has become a big problem within nursing homes, skilled nursing facilities, where it spreads very rapidly from patient to patient and can be difficult to eradicate from both skin and surfaces. Next slide. And then resistance in Candida auris is acquired, not intrinsic. And this is really a very nice paper by Barak and colleagues from just last year. They took a number of isolates from all 4 different clades and looked at those in vitro with exposure to a variety of different antifungals and saw changes in their karyotype, changes in ploidy very quickly. So we think this rapidly develops resistance to a number of antifungal agents. And so it's acquired, it's not intrinsic, but just sort of interesting about Candida auris here to keep in mind. Next slide. So other emerging or even emerged resistance is more in more common Candida species is also seen. And you'll see this on the next slide. So what about echinocandin resistance? So we talked about that just a little bit. That's not as common in Candida auris, but certainly occurs. But Candida glabrata, this has really not an emerging problem, but already emerged. Duke had a really nice description of this about 10 years ago with their experience with echinocandins and Candida glabrata resistance. And you can see that right here, that in Candida glabrata, fluconazole resistance certainly occurs, but also echinocandin resistance. And Joe Heitman's group at Duke has a nice paper talking about this mutator genotype in Candida glabrata that basically causes replication errors and promotes multi-drug resistance in these Candida glabrata species. I think that's an important work because when you treat these patients with Candida glabrata who initially improve on echinocandin and then worsen, it's important to remember that they can develop resistance on therapy. So that's certainly something to consider when you approach these Candida glabrata isolates. Next slide. And then just to finish up, not only echinocandin resistance, but fluconazole resistance continues to emerge, and even in Candida species that have historically been susceptible. So Candida parapsilosis, historically, more than 96% of these isolates are susceptible to fluconazole. But azole resistance really emerged in South Africa over the last few years. That has since there's been a big problem with that in Spain. And most of the isolates have one of these 2 characteristic mutations, this Y132F mutation, which is in ERG11, the target of triazoles. And also this K143R is also found in some of the isolates, not quite as commonly. But interestingly, this is not correlated with prior azole exposure in the Spanish study. These appear to just be in the environment, in the community, and they now are causing disease in our patients. And we're not clear quite yet if those are associated with worse outcomes than other isolates. Next slide. So invasive candidiasis, to wrap up and summarize here, the epidemiology and our understanding of that continues to evolve. There have been recognition of a number of new species and lots of taxonomic changes, which have frustrated clinicians and the microbiology lab alike. There's been the emergence of resistance to both the echinocandins and fluconazole. That's certainly something to be on the lookout for. And then Dr. Vasquez is going to talk about treatment and prophylaxis strategies that must evolve in parallel. So thank you so much for your time.
Thank you, Dr. Thompson. That was really a wonderful presentation. We have rising information about the variety and pathogenicity of these Candida species, and drug resistance is certainly something we should all be mindful about. Next, it's my pleasure to introduce our second speaker, Dr. Vasquez. He'll be covering the diagnosis and treatment strategies. As a reminder to the audience, please use the Q&A button to ask questions at any point in the presentation.
Okay, thank you, and welcome everyone. Next slide. So what I'd like to touch on is really the Achilles heel of fungal infections, specifically Candida, and that's the diagnostic challenges. It's one of the problems we have with candidiasis, not only candidemia, is the fact that there are no distinct manifestations. Number two is the fact that a good percentage of the population is normally colonized with Candida, specifically Candida albicans, and a lot of times it's hard to differentiate colonization versus infection. In fact, from studies that have been done over the past 20, 30 years, we know, although older data, and I'll show you the newer data, the blood culture positivity rates can range anywhere between 40 and 60%. A lot lower in the 20% range, especially in patients that have had even 1 or 2 doses of antifungals, whether it's an azole or an echinocandin. So we're kind of left with, number one is a high index of suspicion, which all of us need to have in those high-risk groups, as Dr. Thompson said, and then starting to consider, although we don't have very good studies, I'm going to touch on the possibility of developing or using some of these prediction rules. Next slide. So one of the keys of candidemia and candidiasis is the fact that about 50%, as I showed you, of invasive candidiasis is missed because the blood cultures are negative. To the left part of the screen, these are most of the patients that have either a line-related infection or an endovascular infection, although generally no deep-seated candidiasis. These are the patients that have frequent positive blood cultures. So it's important to note that this is what we diagnose when we do a blood culture. Moving towards the middle, these are patients that have had candidemia, may have some deep-seated invasive candidiasis, specifically the liver, the spleen, possibly the kidneys. This is where we see occasional positive blood cultures for Candida, and these are one of the disease entities that we miss. And then all the way to the right side, these are patients with deep-seated candidiasis. For example, a patient with intra-abdominal perforation that has leaked from a diverticular abscess, shall we say. These patients, although septic, rarely have positive blood culture. So recognizing the different spectrum that we see of candidemia and candidiasis, we do have to realize what type of disease entities we may encounter. Next slide. So diagnostic modalities, I mentioned before, we're going to touch on blood cultures we've been doing for a long period of time, can range, depending on the study, anywhere between 20 and 70%. The 70% is in patients usually that have a line, whether it's a peripheral line, a central line, a PICC line, midline catheter. So versus the 20%, and those are patients that may have intra-abdominal candidiasis. Number two is tissue cultures for invasive infection. Well, that's great if we know what tissue we're going after. If somebody has an intra-abdominal infection with an abscess, then that's certainly a possibility. But other than that, we rarely get biopsies to diagnose candidiasis. The beta-D-glucan assay, or it's a panfungal assay, we do have to recognize that it does pick up other yeast and fungi besides Candida species. And I'm going to touch on that in a second. The sensitivity is in a range of about 85%. Specificity, depending on the population, somewhere in the 40 to 90% range. Downside to that is that most institutions do not have that in-house, and it's a send-out test, which can take anywhere between 2 and 4 up to 5 days, depending on your institution. And then finally, the PCR-based assays, which have very good sensitivity. Downside is a lot of these are not FDA approved. They are costly, and it's going to be a send-out test. And again, it can take a significant period of time to get the results back. And by that time, it may be too late. Next slide. I'm going to touch on the T2MR. This has been available now for several years, and this is for the direct detection of Candida in whole blood. There is no DNA extraction in this study, and this is a study that was published in CID about 8 years ago, looking at 1,800 subjects. It has been approved by FDA, and you can see the sensitivity there in the range of 91%, specificity 99.4%, and I'm going to touch that and compare that. The unique part, if you have the machine in-house, and a lot of institutions do have it across North America, sample time to result fast, somewhere between 3 and maybe 5 hours. So it's a great test to have as long as you have it in-house. The limit of detection is exceedingly small, 1 to 3 CFUs per ml. So it does have a really good sensitivity. So the following slide. What I'm going to show on the following slide is just a comparison. This is a publication from Fowler, looking at comparing T2 versus the beta-D-glucan assay. And what you can see on the left-hand side is it really depends on the prevalence of disease. If you're doing these assays on somebody walking around in the community with a community-acquired pneumonia, let's say, and a very low prevalence of disease, you're going to see that the positive predictive value is in the 75% range. However, negative predictive value is almost 100%, 99.8%. Compare that to the beta-D-glucan, which has a predictive value of about 9% with a really good negative predictive value. And as a matter of fact, it's one of the assays that can be used frequently to discontinue antifungals because both of these have very high negative predictive values. Now, if you start doing these assays in somebody in the intensive care unit with a couple of risk factors and this high index of suspicion, then you can see that predictive value actually increases more than 20%, and you hit a 98.6% predictive value, considering maintaining a negative predictive value at the 96% range. The beta-D-glucan goes up to about 70% predictive value and a negative of about 89%. So you can see the two probably most commonly used assays that we have available right now in North America, the T2MR and the beta-D-glucan. Next slide. So let's touch on now what we've made a diagnosis of, say, candidemia, or we have an intra-abdominal abscess, or we have Candida. Key to all of this is the fact that all fungal infection, the important part is management of the host response. If there is no host response, or if you don't have host response, then the outcome and mortality is extremely poor. Mortality is very high. So if it's a catheter-related infection, if at all possible, it's actually almost mandatory to try to change that catheter, remove the catheter to eradicate the source, especially from a candidemia. Drainage of an abscess, wherever that abscess may be, is essentially mandatory. Source control, again, is the key. And then, as I've mentioned, host response is the key. So removing or decreasing immune suppression, dropping prednisone, dropping any of the immune suppression that maybe solid organ transplant patients are on, and certainly restoring immune function. Neutropenia, the white cells are Marines, if you will, to fight fungal infections. And over the past 30 years, it is rare that I've seen a patient survive an episode of candidemia or invasive candidiasis if they do not recover their white count. So white count, normalization of the white count is key. And then finally, most importantly, beginning antifungal therapy as early as possible. You can see there the sub-bullet point, do not wait to initiate antifungal therapy for a positive blood culture in patients at high risk. Matter of fact, the best and the most optimal is to initiate antifungal therapy certainly within 12 to 24 hours. In addition to that, one of the areas that we have to consider, Dr. Thompson discussed it, is a good ophthalmologic exam, preferably dilated ophthalmologic exam. Although endophthalmitis has decreased significantly over the past 2 to 3 decades because of the early initiation of antifungals, we still see it, and it's still a significant problem. And the reason it's important is obviously, number one, if we're using echinocandins, well, echinocandins don't have great penetration. And number two is the fact that we're going to have to go longer than the usual 14 days of therapy for these patients. So important to rule out a fungal endophthalmitis in this situation. Following slide. Go ahead, next slide. All right, so this is actually, there are several of these studies. This is the one that I think I've used for many years. And what it shows is the increased risk of hospital mortality with a delay in antifungal therapy. So the longer we wait to treat, the longer we wait to initiate appropriate antifungal therapy, the higher the mortality. This is from Morel et al. Out of WashU in St. Louis, published more than 15 years ago. And what they looked at is the hospital mortality in association with initiating antifungal therapy. And what we see that the odds ratio is 2. So odds ratio 2 times greater rate of mortality in patients that had antifungals initiated more than 12 hours compared to those, and there weren't very many, only 9 that had antifungals. So mortality rate, if you had the appropriate antifungal initiated within the first 12 hours, was about 10%. Just comparing 12 to 24, 24 to 48, you can see the mortality rate increases dramatically to what we're used to seeing, unfortunately, in the 30 to 35% range, which is where it has been for the past several decades. For that reason, is the delay in initiating antifungal therapy. Following slide. So once you select an antifungal, echinocandins, ever since the guidelines were published in 2016, the echinocandins are basically the front line or the drugs of choice to initiate antifungal therapy. We have had inidilafungin, caspofungin, and micafungin now for quite a few years. More recently, over the past 2 months, we have had a new echinocandin that has been FDA approved for candidemia and invasive candidiasis, and that's resifungin. And unique about resifungin is the fact that after a loading dose of 400 milligrams, it's followed by a weekly dose. So it's a once a week antifungal echinocandin. These are especially recommended echinocandins in patients with any prior azole exposure because of the shift of susceptible to resistant, and any patient that you know has maybe colonized with or infected with either Candida glabrata, Candida krusei, and certainly Candida auris. Following slide. So here's the big question that we frequently face in patients in infectious disease. This is the consultation that we get from a medical ICU, a surgical ICU, and is patient that's septic on broad spectrum antimicrobial therapy. At our institution, it happens to be vancomycin or vancomycin, and the patients now are going on pressors and they don't seem to be responding. Next. So the question for these patients, next slide, is should we start empiric or early presumptive antifungal therapy on everyone that meets these criteria? Febrile, culture negative, several risk factors, and they're basically septic, number one. Number two is what criteria do we use to initiate early presumptive therapy or empiric therapy, if you will? And number three, I think the last question is quite easy. What antifungal do we start? And that certainly should be an echinocandin. So important note, and this is one of the areas that is still a very large gray zone, is when should we start empiric antifungal therapy in these types of patients? Next slide. So this is one of my favorite studies that I keep quoting. This is from 2000, and it's from Mayo Clinical Proceedings. And what they looked at was a comparison of antemortal clinical diagnosis in ICU patients and their subsequent autopsy findings. So they looked at 100 adult MICU patients, and what they found was 81% of the antemortem diagnosis was actually confirmed. So they're actually pretty good, right? So 80% of the diagnoses were confirmed on autopsy. The most common cause of death in this study, granted retrospective, was a bacterial pneumonia with multi-organ failure. However, they also had 36 misdiagnoses. And of the 36 misdiagnoses, these were classified into class 1 errors and class 2 errors. Class 1 errors, there were 22 misdiagnoses. And what class 1 error, the definition was an autopsy finding that revealed a diagnosis that if they may have known it ahead of time prior to death, it may have actually led to a change in therapy and subsequently no mortality or decrease in mortality. And if you look at the most common causes of misdiagnosis, there was only one infection, and that infection was systemic fungal infections in 5 out of the 22, or 36%. It's the only infection that was missed in patients in the intensive care unit. The other ones are actually obviously non-infectious complications such as cardiac tamponade, the abdominal bleeds, and myocardial infarction. But key to this is we're always switching antibiotics back and forth But the problem is not antibiotics back and forth and resistant organisms. The problem when we're missing it is a fungal infection, an invasive fungal infection. Class 2 errors, there were 14 of these. And that definition, there was no effect. There were 6 patients that had cancer that died, 3 with mesenteric ischemia, and 2 that had pulmonary emboli. So again, important to note, most common, systemic fungal infection. Next slide. So what about early presumptive therapy in this high-risk group of patients? Well, studies show that there's a benefit, as I just mentioned, initiating early and appropriate antifungal therapy. Number 2, however, is there have been several of these studies that have been done and evaluated. And it's actually been very disappointing because we don't really have great prediction rules or great recommendations on when to use or when to initiate early empiric therapy or early presumptive therapy. So they're still out there. We have a gray zone is how to identify some of these high-risk patients. Well, groups out of Spain actually used Postoraro and et al. Came up with a Candida score, which is kind of interesting if you want to take a look at that. And Ostrowski and colleagues, mycosis study group, actually had come up with some prediction rules, which may be beneficial. But again, a lot of these studies to initiate therapy have been kind of disappointing. Following slide. Finally, to round this out, I'm not going to touch a little bit. I'm not going to go through this because Dr. Thompson kind of went through it, except to recognize the increase in non-albicans Candida species, and I still prefer to call it Candida glabrata. We do have to recognize that it has taken over many institutions and that 30 to 4% of the Candida glabrata are now resistant to fluconazole. And if they're resistant to fluconazole, they are also going to be resistant to voriconazole. And we're starting to see this increase in echinocandin resistance very slowly. He mentioned the fluconazole resistance in Candida parapsilosis, which I think is creeping here in the United States, along with the multi-drug resistant Candida auris, and there's probably about 1,000 cases now in North America. Rare to have multi-resistance with azole, polyene, and candin, but I think it's just the tip of the iceberg, and then finally Candida krusei. Next slide. Finally, what I'd like to point out, it is key and important, is that all institutions nowadays really has to have an antifungal stewardship, not only for the initiation or use of antifungals, but also for the use and initiation of rapid diagnostic assays and techniques to initiate antifungal therapy. So the stewardship increases our awareness of candidiasis, hopefully increases the diagnosis, the early diagnosis of candidiasis, and focuses on therapy. In addition to that, that infection control and prevention is key. We actually have something at our institution called plastic rounds, where we will go around and we'll try to eradicate everything plastic that's in a patient, if not really necessary, and the recommendation for a stewardship consultation if the physicians want a PICC line or midline catheter, especially if they're going to be used for antimicrobial therapy. This not only improves line-related infections, but fungal infections, improves antimicrobial utilization, hopefully decreases length of stay, decreases morbidity and mortality, and because of that, hopefully avoids resistance and selection pressure. Next slide. With that one, I will end my presentation and I'll send it back to you, Dr. Legovila.
Thank you, Dr. Vasquez. That was a tremendous presentation covering a lot of topics. And we have a couple questions in the chat. So, okay, Dr. Thompson, your video is back on. If both of you could please unmute. So our first question in the chat was, does anybody have any insight into when the next IDSA Candida guidelines might be released? The last guidelines were published in 2016, and
Right.
Since then, a lot of information and new drugs have come out.
So I can say that we've discussed it, and I'm Dr. Thompson as part of the same committee. It has been discussed, but because of really a dearth of information of changes or significant changes, we have not done anything at this point in time, although now possibly with new antifungals around the corner, it's a possibility we will start to discuss the new guidelines.
Okay. Well, we look forward to it.
Yeah.
Question number 2. Now, One question was, is there any updated data on when the NICU should consider prophylaxis for extremely low birth weight infants?
That's a good question. We're both adult infectious disease doctors, so I'm trying to remember back to that New England Journal paper, but I thought that the incidence, if it's 5 to 10% in the guidelines for extremely low birth weight infants to consider fluconazole prophylaxis. So I think 10% it's kind of on the high end there, but I'm not aware of any new studies. But Joe, are you?
No, I think we actually use 5% for fluconazole prophylaxis, although it actually is changing now, even in the pediatrics and NICU, because they are also starting to see some resistance to fluconazole. And a lot of them have actually had to switch and go to Candida as well. So probably because of the prophylaxis that's being used in the NICU.
It's a delicate balance. You know,
Yes,
what's
it
the
is.
risk and what's the reward? The patient in front of you or the population?
Exactly. But again, I mean, both Dr. Thompson and I are adult IDs, so that is probably not our area. And maybe having a pediatric infectious disease chime in may be helpful.
I think that's really good feedback for the IDSA Foundation. We should have some pediatric topics. I
Absolutely.
similarly an adult ID, and I'm cautious.
Yes.
So maybe Dr. Vasquez, this question's a bit more for you. Why has the mortality rate of invasive candidiasis not changed over the last 20 years?
So that's a really good question. It's something that's frustrated me for 30 years, actually. As a fellow, the mortality rates that I used to hear from my mentors was, well, mortality rates are in the 30 to 40, 50% rate, you know? And if we do more recent studies, mortality rates are still hitting in the 30% range, even in areas and places where there's a higher risk or suspicion, if you will. And I think the reason is one of the slides that I showed you is the fact that we wait for a positive culture. And as I showed you before, if we wait for a positive culture to initiate therapy, it's probably too late for a lot of these individuals. So we have to realize that our diagnostic assays or techniques are not great. They're not good. And we can't wait 3 or 4 days for a beta-D-glucan or a T2 for being sent out. So I think the reason is a delay in diagnosis. And because of the delay in diagnosis, there's definitely a delay in initiation treatment, appropriate treatment.
Right. The high index of suspicion sometimes is really difficult to.
Yeah, and I think number 3 is the fact that we still have to do good studies to try to establish a good prediction rule of when to initiate appropriate antifungal therapy, right? So that's something that has been tried and has been done, but most of the results are really disappointing. And everybody's got a different way of handling things. So I think it's still an area, a big gray zone, and probably, as I mentioned, the Achilles heel of all fungal infections, not just Candida, is, and because this has been shown for Aspergillus, been shown for Mucor, is the longer we wait to initiate an appropriate antifungal, the higher the mortality rate. So we have to realize we're not really good at making a diagnosis unless we have that positive blood culture. By then, it's probably too late.
There's a few comments in the chat regarding candidemia and endophthalmitis. And I'm sure, as you know, there was a position statement from the ophthalmology group about not routinely doing ophthalmologic examinations on candidemic patients. In your clinical practice, in your experience, do you have any comments? Do you support doing routine eye exams or in selected patients? What are the clinical factors that you would consider?
Yeah, I'll take that, I guess. That has certainly been a big debate. I mean, the ophthalmology group wrote really a consensus opinion a couple years ago now, I think, that really did a meta-analysis of a large number of patients. I think there were over 7,000 patients in that study, and saw a very low rate in that. I think it was less than 1%. And that was kind of the basis for where they said, you know, we don't need to do this anymore. And I certainly understand their view that they really don't like to come into the hospital. They'd prefer to have patients come over to clinic. We've been very fortunate that our ophthalmologists have continued to do that. That's obviously a regional sort of dogma. we take a careful history for those that any visual abnormality needs to definitely have an ophthalmologic exam. And then patients who can't give a history, ICU patients, they definitely need to have an ophthalmologic exam. And then there's a few caveats for when to do the examination as well. So neutropenics, you're going to want to wait till their neutrophil count recovers. You won't see their vitritis often if they're still neutropenic. So we've been fortunate that ophthalmologists are still willing to do that. But this is clearly a debate. I think it's even going to be one of the debate series in ID Week this fall to have sort of a pro and con argument for that. And there is a clinical trial planned to evaluate this prospectively as well. So I think the mycosis study group has acknowledged this debate and are hoping to definitively answer that. Joe, any follow-up comments?
Yes, I do. So we actually are pretty lucky here as well, although we have started to get a little bit of a pushback, maybe more so from the residents than the faculty, because they don't want to do an ophthalmology consult on the patient. But our practice still here is that we recommend it on patients that have candidemia. So, and as long as that is, and I don't think, I mean, we've actually looked at, several hundred patients here, and our incidence was not less than 1%. We actually were running about 5 to 6%. So I'm not sure about the meta-analysis at less than 1%. I think it's higher than that, but it really depends on where you're at, I think. So definitely somebody who can share their complaints would be a very, very important candidate to get an ophthalmologic exam. So.
Excellent points. There's a couple more questions about the management of candidemia. I'll try and lump them together. So one question is, can you speak to the utility of polydrug therapy, such as adding flucytosine for difficult to clear candidemic patients? And are there any concerns with the use of mycophenolate and the potential for endophthalmitis, knowing the CNS penetration of echinocandins?
Right. So I'll take one of them. So there have yet to be any good studies to show that combination therapy is any better than monotherapy. In vitro and in animal studies, there's a possibility of some additive effect with the combination of an azole and an echinocandin, and an azole and a Pauline, which is something that for many years we did not do, and we didn't mix those. But in clinical settings, there have not been any studies to show any effect. So usually when I have a patient who has a sustained candidemia, it's 99% of the time is because they either have an endovascular infection, meaning cardiac is not an uncommon one, or a myocardic aneurysm somewhere, and then lastly, some hepatosplenic. So I think if somebody has sustained candidemia, one of the areas that we always forget to take a really good look is the heart, because it's not that common, right? Candida endocarditis is not that common. And let's face it, that even a transesophageal echo is not that great for, and not all candida lesions on valves are the stated, 2-3 centimeters. They're not very large. A lot of times they've actually been flipped off. So we have missed quite a few of these in these patients. So I don't think it's necessary to initiate combination therapy. If you have sustained infection, I think you need to look for a source. And there's a hidden source somewhere of the 3 that I just mentioned.
Yeah, and that brings up an interesting controversy as well. The European Candida guidelines, they recommend echoes for everybody.
Yeah.
And that's really not been our practice with the IDSA. I have a very low threshold to do an echo on our patients with candidemia, but I certainly don't do it for all of them. So well taken. And then, Mary-Rose, your other question was about echinocandins for endophthalmitis. One of the papers I think that's kind of added to this debate with eye exam was an OFID just a couple years ago, and it had shown sort of an increase in ocular infections over time, and they had sort of posited that echinocandins may be a contributor to that. Since they have poor ocular penetration, you may have more eye involvement with echinocandins as first-line therapy. I think that's interesting. Again, I think that only thing that's going to answer this definitively is a prospective study. So I'm hopeful we can conduct that over the next few years.
Yep.
We have many other really good questions. So going into some questions about resistance, a comment was definitely alarming to see the Candida glabrata fluconazole resistance at 30 to 40% now. Do you have a feel for the percent that is at the susceptible dose-dependent range of 16 micrograms per ml, or is that included in the 30 to 40%?
Well, that's included in the 30 to 40%. So that's where we are, although the breakpoints have actually changed recently, right? That data is actually prior to changing the breakpoints. So if you use the new breakpoints, that resistance rate is much, much higher than what it is right now. So, and the other scary part is that we're starting to see some of these azole resistance in glabrata. As a matter of fact, I just had a patient come in with a glabrata and tropicalis. So definitely azole resistance is increasing all across the world. And it's something that we have to take into account. And not all azole resistance is the same. The azole in Candida glabrata is not the same thing as fluconazole resistance in Candida parapsilosis.
Okay. There was a question about how antifungal susceptibility testing may not be readily available at centers. So for those clinicians, is there any value in knowing what your local prevalence is of the species which tend to be resistant, or is there anything else that collaboration with the microlab and a fungal antibiogram could be useful?
Yeah. You want to take that, Dr. Thompson?
Sure. Yeah. I mean, I think that we are a bit behind in this area. I mean, we've become very used to creating institutional antibiograms, but have not typically done that with antifungals. Fluconazole disc diffusion is very cheap, can be done locally. It does not require a lot of expertise. Echinocandin testing, typically does. A lot of those are send outs for people, and that may not impact, what you're going to do up front just because of the delay and the turnaround for that. But I do think it's really essential to have some semblance of an understanding of what your local epidemiology is. And that can probably be built on by stewardship, but also if you use a whole lot of echinocandins, like if you have a group in the hospital that uses a lot of echinocandins as prophylaxis, you're going to have more echinocandin resistance, and it's important to know that and to look for it. So if you think you have no resistance, it's probably because you're not looking,
Right.
Because we all have these.
Yeah. So as I mentioned, I think you're right. We really push, and everybody has to have an antimicrobial stewardship, but we always forget about an antifungal stewardship, right?
Mm-hmm.
And it should be built into that. And I think that's a great way. Number one is to monitor your epidemiology. Every institution is different. Some institutions, large tertiary care centers with trauma and transplants, are going to have a much different rate of Candida glabrata versus Candida albicans, and a much different rate of azole resistance and echinocandin resistance in that setting versus a community hospital, if you will. So I think just monitoring, number one, is the epidemiology or the species, over a period of time with your antifungal stewardship. And then I certainly am not all Candida require in vitro susceptibility, but I think anytime you're treating Candida, either bloodstream or from a sterile site, I think nowadays you really have to do some kind of in vitro susceptibility so you know what you're treating.
Oh, excellent points. So we have a few more minutes. There are some questions about some of the newer antifungals. So one question is, can you talk about the therapeutic options in the pipeline for multi-drug resistant Candida auris, such as ibrexafungerp? And also, is there any data about rezafungin for Candida auris being any better than other echinocandins?
I'm not aware of any clinical data for rezafungin with Candida auris. That was not in the phase 2 or 3 studies. In vitro with rezafungin, there's really fantastic activity for some of the CRS isolates with resistance to the other echinocandins, but there's also resistance as well seen. So it's, and in that report, I think it was about 50-50. They still have low MICs about half the time. Ibrexafungerp has some clinical data that Nkechi has presented from I think it's the CARES trial, and had pretty good success with Ibrexafungerp. So I think that's a potential option as well. And then fosmanogepix has finished a phase 2 trial, and I don't remember if there's any CRS isolates in that report. Joe, do you recall?
No.
I just don't remember them being in there. I mean, I think that's probably a potential option as well, but a little further back in the clinical development.
Yeah, so I think, so right now what we are, and I think you may be a part too, we're we're doing a phase 3 study with ibrexafungerp for Candidemia and Invasive Candidiasis. And it's getting there. It's about halfway there. So there's still some to go, but that is definitely something in the pipeline that hopefully in the next Candidemia studies take several years to do, as you're aware. So it may be a couple of years out, but at least it's in phase 3 studies. The fosmanogepix is stuck in phase 2 at this point in time. I have not seen any studies for phase 3, although they had discussed it at this point. And other than that, I don't know. Those are the only 2 really in the pipeline at this point in time.
Well, at least there's something in the pipeline.
Yes, you're right, right.
All right, well, we're just about out of time. And so thank you very much to Drs. Thompson and Vasquez for your excellent presentations. If there were any questions that we missed, we'll do our best to answer you in the email. And for now, I'll pass it back to Allison.
Thank you so much, Dr. Lagiovila. And thank you so much for your exceptional hosting skills and for joining us and taking time away. I also want to express my sincere appreciation to Dr. Vasquez and Dr. Thompson. If you wish to revisit this webinar or share it with others, a recorded session is going to be made available on our website at the IDSA Foundation and our YouTube channel. And I'm also going to invite you to connect with us on our social media channels. If you're interested in becoming a member of the Infectious Diseases Society of America, please don't hesitate to reach out to us or visit our website. The premier conference, ID Week, hosted by the Infectious Diseases Society of America, will be taking place in Boston this year from October 11 to 15. Registration is now open for IDSA members and will be opening to non-members starting June 6. We look forward to seeing you there. The Dr. John G. Bartlett Memorial Education Series is a non-CME webinar series that really delves into the captivating world of infectious diseases. We have an upcoming webinar that is scheduled for Thursday, June 15th at 1 p.m. Eastern Time and 10 a.m. Pacific Time, focused on post-transplant CMV. If you're interested, a registration link has just been provided in the chat, and we invite you to join us. Last but not least, we ask you, and I would like to ask you, to kindly consider furthering your support of the IDSA Foundation through a donation. Your contribution plays a pivotal role in advancing our mission and our work in workforce development and makes a tangible impact in our field. So thank you again to our panelists, to our host, and we'll close now on that note and hope everyone has a terrific day.
Bye-bye.